Welcome everyone to this online presentation sponsored by HRA Pharma Rare Diseases about the clinical management of adrenocortical carcinoma. My name is Mohammed Habra. I'm an associate professor at the Department of Endocrinology at MD Anderson Cancer Center in Houston, Texas. And this is my disclosure. In this presentation, I will be summarizing practical aspects about the diagnosis, epidemiology, and management of advanced adrenocortical carcinoma, with particular emphasis on the use of mitotain in adrenocortical carcinoma, which I'll refer to as ACC in this presentation. As an introduction to this presentation, we will start with the epidemiology of adrenocortical carcinoma. ACC originates from the adrenal cortex, where steroid hormones are produced, mainly cortisol, aldosterone, and sex hormones. And this is important because ACC is a rare disease and seen almost in 1 person per million population per year. However, endocrinologists are expected to face ACC more than other specialties because of the hormonal symptoms which can be seen during ACC. Another important aspect of ACC that ACC has bimodal age distribution. We see a small peak in children, which is often associated with Li-Fraumeni syndrome, but we see a larger peak in adults in their 4th and 5th decade of life. Women are often diagnosed more than men, and there's a slightly more cases in women than men. And this is something important, which is likely because ACC with the hormonal overproduction could be easier to recognize in women compared to men. In the coming few minutes, I will focus on the practical aspects about the diagnosis of ACC, including the laboratory and imaging workup. This is a suggested diagnostic workup for ACC based on the European Society of Endocrinology recommendations, which is also sponsored by NSAID group. In this, there will be a need for checking multiple hormones in ACC. Oftentimes, ACC produces more than 1 steroid, which can be cortisol with androgens or aldosterone with androgens, and oftentimes there will be production for more precursors. With this recommendation, there will be a need to check for cortisol overproduction, which can be done using 1 milligram overnight dexamethasone suppression test. Also, urine-free cortisol can be also utilized. Other things which can be checked, including sex steroids, DHA sulfate, testosterone, for example, 17-hydroxyprogesterone, which are also included. 11-deoxycortisol is also oftentimes elevated in ACC, even sometimes in the absence of other hormonal elevation. Oftentimes when we see patients with large adrenal masses, we must rule out pheochromocytoma, at least checking plasma or urine metanephrine to rule out pheo during the approach for large adrenal masses. In terms of imaging studies for ACC, there is a need for cross-sectional body imaging, including chest, abdomen, and pelvis. This can be done with CT scan, MRI, or even FDG PET scan. Routine bone and brain imaging is not indicated. Oftentimes, ACC rarely goes to the brain. So as part of the initial staging of ACC, we tend not to do brain MRI unless someone having neurological symptoms or there's suspicion for brain metastasis. And these are 2 examples for 2 patients with large adrenal masses, which turned out to be ACCs. The case on the left, referred to as with the white arrow here, it's a large right adrenal mass, heterogeneous mass, suspicious enough, but again, this cannot be distinguished based on radiology to be ACC. This could be ACC, this could be pheochromocytoma, this could be other suspicious adrenal masses. That's why the hormonal workup aids the diagnosis, and it should be used in collaboration with the imaging studies. Hormonal evaluation and radiological evaluation should be done together to better assess what this mass might be. On the other case, which is, referred to here with the red arrow, you see another large left adrenal mass here, which also turned out to be ACC. This feature, the size, is an important feature to raise the suspicion this could be ACC. However, size alone cannot rule in or rule out ACC. So we have to do the full workup. Staging and prognostic factors, I will be mostly focusing on the key practical prognostic factors which are in use in clinical practice without going to other research items. Stage is very important in ACC, and ACC staging, which has been proposed by the ESAT group in almost 2009 and has been adopted by the AJCC 8th edition in 2018. The staging, when the tumor is confined to the adrenal gland, it will be either stage 1 or stage 2. If it's 5 centimeters or less, it will be stage 1. More than 5 centimeters, but still confined to the adrenal gland, it will be stage 2. Stage 4 is defined by having distant metastasis. So the only criteria for distant metastasis, the only criteria for malignant for stage 4 ACC is having distant metastasis. Why staging is important? Because this is, again, one of the most important prognostic factors in ACC. What we know that the 5-year survival for an ACC stage 1 is about 80%, and this goes down to about 13% to someone presenting with a stage 4 ACC, as you can see in the survival curve on the right side. The other important factor, prognostic factor in ACC, is hormonal overproduction. As we mentioned earlier, most ACCs produce more than one steroid. And this is, again, data from different retrospective series. And you see difference in the estimation of the hormonal overproduction, which is likely because of the difference in the method of testing. But again, majority of ACCs, they produce more than one hormone. And cortisol will be the most important one. So cortisol production is, again, a prognostic factor. It's, obvious that too much cortisol can lead to other complications such as diabetes, hypertension, hypokalemia, hypercoagulable state, which can complicate the management of these patients. So what you see here on this survival curve is relapse-free survival and overall survival in patients with localized ACC who had complete surgical resection. And what we see here, patients who had cortisol overproduction, as you see in the dotted blue line, they have worse outcome, which means shorter relapse-free survival and shorter overall survival compared to patients without cortisol overproduction. This was seen in another series here, as we published here in the middle graph here from MD Anderson, and this has been also confirmed, actually suggested also in another meta-analysis. Another practical prognostic factor is measuring the proliferation rates of ACC. The most commonly used test is Ki-67, which is a protein made in dividing cells, and this can be assessed with immunohistochemistry. In this important paper here, looking at the importance of Ki-67 in ACC prognosis, and what we see here on the left side, we see a German cohort and validation cohort here, and the upper panel here, you see the recurrence-free survival, and the lower panel is overall survival. So using Ki-67, ACC can be divided into low grade, intermediate grade, and high grade. Again, Ki-67 less than 10%. These patients tend to have much better prognosis compared to someone with Ki-67 more than 20%, as you see here in the green line, less than 10%, in the red line, more than 20%. To the point that each 1% of Ki-67 is associated with about 4% increase in recurrence rate. Another practical aspect, checking the resection margin. Again, this applies to ACC, which is amenable to surgical resection. Patients who can have R0 resection, meaning complete surgical resection with negative pathological resection margins, tend to have lower recurrence rates compared to someone who has R1 resection margin, which is microscopically positive resection margin. This adds to the importance of finding the right surgeon who has enough experience to do these cases to achieve an R0 resection. Regarding ACC management, I will briefly go over the management of localized ACC, which means a disease which seems to be confined to the adrenal gland or minimal extension beyond the adrenal gland, but still surgical resection seems to be doable. And then I will be discussing the management of advanced ACC. So the management of localized ACC, there will be a need in many of these patients for preoperative management, whether it's blood glucose control, management of hypertension. And there's no prospective data about this, but this, makes clinical sense, to control some of the comorbidities associated with ACC, especially in the cortisol-producing ACCs. Regarding the surgical management, as we discussed, the goal is having an R0 section, and having the right surgeon is a key step in ACC management. And after resection, these patients need to be followed for extended period of time, minimum every 3 months for the first 2 years, and then less frequently after that. And because most recurrences will happen in the first 2 years after resection. For most patients with advanced ACC, which means either stage 4 or unresectable stage 3, or patients who have recurrences, because one of the key features of ACC is high recurrence rate, which can be about 50 to 70%, even after complete surgical resection. Again, this is also a suggestion based on the recent NSAID-ACE guidelines. When facing advanced ACC or recurrent ACC, these patients often need systemic therapy. So mitotine is, the only FDA-approved, treatment in advanced ACC, and it's the cornerstone in these patient management, especially in the hormonal producing ACCs. Mitotine is often used in combination with chemotherapy, and this is the most commonly used chemotherapy is etoposide, doxorubicin, cisplatin, and these patients get these treatments in cycles and get re-imaged every 2 to 3 months to assess response to therapy. Some patients can start on mitotine alone, especially if they have, low burden of their disease and it's not very aggressive initially. And these patients can be monitored with single agent mitotine initially and adding chemotherapy as a second step. The reason why we mentioned EDP and not other regimens, because there is only one completed phase 3 clinical trial in ACC comparing 2 commonly used regimens. One of them is etoposide, doxorubicin, cisplatin with mitotine. The other regimen is combining streptozocin with mitotine. And this was the Firm Act published 8 years ago. And with this, we see in the red line here are the patients treated with EDP mitotine, and in the blue line, patients treated with streptozocin mitotine. And what we see with this is the progression-free survival in these patients was 5 months with EDP mitotine compared to about 2 months with streptozocin mitotine. There was no significant difference in overall survival because this study allowed crossovers, so overall survival would be hard to assess based on the study design. And since, this study was published, EDP mitotine became, the most commonly used chemotherapy in ACC. Mitotine, we'll spend a few minutes about mitotine, and I will start actually with the black box warning. We already mentioned that mitotine is the only FDA-approved treatment for advanced inoperable functioning or non-functioning ACC. But also there is a black box warning about adrenal insufficiency, which might require, of course, it will require routine hydrocorticosteroid replacement, but might require also hydrocortisone injection and patient education about the potential for adrenal crisis. I will spend a few minutes about the mechanism and how mitotine works. So even mitotine has been in use for about 5 decades. There are so many questions still about the details of the mechanism of action. There is data about that mitotine will alter the metabolism of steroids, whether it's through the alteration of the production, blocking the key enzymes which are associated with the steroids production, and it also increases the clearance of steroids, which we often give by mouth as replacement. And this is a very important aspect in the management of adrenal insufficiency in the context of mitotine therapy. There are some papers suggesting mechanisms of action of mitotine. In the first paper here, mitotin can change the mitochondrial function, leading to cell damage. And in the second paper, mitotin can block SWAT1, which is important in the cholesterol metabolism, and that increases free cholesterol in the cells, leading to more stress in the cells, leading to cell death. And in the coming few slides, I'll be summarizing few practical aspects about mitotin dosing and monitoring, because this is again what people who often, this is one of the main reasons for questions which I get about mitotin therapy. It's important to know that mitotin is a lipophilic drug, which means it has high volume of distribution, which leads to two phenomena. It takes few months for the mitotin levels to achieve what we consider as therapeutic/oncological drug level because of the fat solubility, and this is something we face often more frequently in patients with increased body fat. So in general, it will take 3 to 5 months before we reach therapeutic mitotin level. The other aspect, of this is also when we stop mitotin, we have to presume that these patients will still have mitotin in their system for a few weeks, if not for a few months. And that's why cutting their steroid replacement prematurely could lead to adrenal crisis, because these patients are still under mitotin effect for a few months after stopping the therapy. When we start mitotin, oftentimes we start with a dose ranging between 2 and 6 grams per day. My personal approach is to start about 2 grams a day and increase the dose within a week till reaching about 4.5 grams a day. This is my personal approach. Sometimes I go up to 6 grams a day. And we have to wait and give these patients a few weeks before we can recheck their level, with expectation that most of these patients will not have the therapeutic level initially. Again, the mitotin has to be given in divided doses. Oftentimes we give it with fatty foods to enhance the absorption. And while we're doing the mitotin, besides checking and monitoring for toxicities and mitotin level, we do imaging studies periodically, as we mentioned earlier, every 2 to 3 months, to gauge if the treatment is effective or whether other treatments needs to be added. So the magic numbers, here is what's considered the therapeutic mitotin level. This is again done based on retrospective data. The therapeutic level which we look for is between 14 and 20 milligrams per liter. It's important, to notice that there are publications suggesting that to have oncological effect of mitotin, the level has to be above 14. At the same time, there is an increased incidence of neurotoxicity when the mitotin levels are above 20. So with this, I will go over some precautions and side effects of mitotin. We already discussed the black box warning about adrenal insufficiency, CNS toxicity, dizziness, memory issues, lightheadedness. We often see it when the mitotin levels are above 20, and it's often reversible when the levels go down. And there is also precautions to avoid pregnancy because of the potential for embryo-fetal toxicity here. Ovarian cysts are commonly seen in women, and sometimes we see gynecomastia in men. So these things are likely related to the increases in the binding proteins, leading to some of these hormonal syndromes which we see sometimes during mitotin therapy. So as we mentioned, adrenal insufficiency is one of the most important and most life-threatening issues which patients can face during mitotin therapy. That's why education is needed, and these patients need to start on steroid replacement when they start mitotin therapy. My personal approach is often to use either hydrocortisone or prednisone in these patients. In addition to that, we mentioned that mitotin increases the clearance of steroids which are given by mouth. That's why when we give hydrocortisone, if we presume the typical replacement for adrenal insufficiency with hydrocortisone is between 20 and 30 milligrams a day, oftentimes these patients will need 2 to 3 times more just for hormonal replacement during mitotin therapy. There is another important feature during mitotin therapy. Mitotin is a major inducer of CYP3A4, which is a key enzyme to metabolize so many drugs. And we mentioned few here, including warfarin. So someone on warfarin, we have to be careful monitoring their INR during mycotin therapy. And there will be other drugs, including many antibiotics, many antidepressants, many drugs metabolized by CYP3A4. We have to presume these drugs will likely be less effective during mycotin therapy, and we have to pay attention to that. And we mentioned the binding protein issues, which can affect, the interpretation sometimes of some of the hormonal, which we do during ACC surveillance and long-term management. The adverse effect, again, a monitoring plan, as we discussed, GI side effects will be among the most common side effects of mycotin, nausea, vomiting, and sometimes diarrhea. And it's hard to ascertain if the symptoms are just from mycotin or are they in parts related to adrenal insufficiency, which is not well replaced. Oftentimes, I see in my clinic patient having lots of fatigue, nausea, and vomiting. And this is simply something can be fixed within a few hours by adjusting their steroid replacement. That's why we hit repeatedly on the adrenal insufficiency issue. Other rare side effects or less common side effects include skin rashes, which is infrequent. We sometimes see elevation in liver enzymes. We see gynecomastia, as we mentioned. There will be changes in thyroid hormone levels, oftentimes in normal or mildly elevated TSH with low free T4. So the lab picks the other side effects are rarely, such as hemorrhagic cystitis and hematuria, but these are infrequent, but still needs to be monitored clinically. So this is a suggested monitoring plan for during mycotin therapy. In addition to monitoring mycotin level initially every 3 to 4 weeks, and then when patients reach therapeutic level is then we start doing less frequent monitoring. We often check other labs, including CBC for safety, to look for any evidence of leukopenia, thrombocytopenia, or even anemia, which are infrequent during mycotin therapy. We check ACTH and plasma renin activity to gauge steroid replacement. Liver functions, as we mentioned, because of the potential for elevation in liver enzymes during mycotin therapy. Sometimes this rarely can require even holding mycotin therapy or even discontinuing, but this is very infrequent. We check thyroid functions. Lipid panel, we check it periodically, and sometimes we have to offer lipid-lowering therapy. Mycotin can increase LDL level, but more importantly, it raises HDL levels. So that's another unique feature of mycotin. With this, I will conclude that the ACC management often requires a multidisciplinary team with known experience in this disease. And there will be many aspects needed: oncological aspects, surgical aspects, endocrine aspects, and a team of physicians need to work closely with each other to achieve the best outcomes for these patients. And we still don't have good prospective data about the hormonal management in ACC, but it's prudent to manage these hormonal symptoms and syndromes which can be seen in ACC localized or advanced during the other treatment, which can be surgery or chemotherapy. Then, the other important aspect we mentioned about mycotin, knowing adrenal insufficiency and the long half-life mycotin, which have practical implications on ACC management. And lastly, I want to mention that reaching mycotin level between 14 and 20 is our goal here to achieve therapeutic and oncological efficacy, and also to reduce the chance for neurological complications. Thank you very much for listening.